Hello and welcome to my YouTube channel, AnatomyMentor. Today we're going to be discussing the part 2 of the topic, which is the histology of the respiratory system. And in today's discussion, we are focusing on the histology of the alveoli. So our learning objectives for today are that we shall discuss the components of the respiratory membrane and the role of the type 2 alveolar cells in surfactant production and respiratory distress syndrome. We shall also identify the role of interalveolar septa in preventing alveolar collapse, and we shall discuss the histological basis of hemoptysis in cardiac failure. So starting with today's topic, the respiratory bronchiolar unit is something I would like to recap from the previous discussion. So this was the smallest functional unit of pulmonary structure, and it consisted of a single respiratory bronchiole and all the alveoli that it supplies. Respiratory bronchioles are the first part of the bronchial tree that allows gaseous exchange. So this is a bit of recollection from the part 1 of histology of the respiratory system. We talked about respiratory bronchioles, that they have scattered alveoli in their wall, and that permits some gas exchange. We also mentioned the alveolar ducts that have almost no walls, but only alveoli as their peripheral boundary. And then the alveolar sacs, which are spaces surrounded by clusters of alveoli. Well, here is the histomicrograph, which is showing us a terminal bronchiole that is leading into the respiratory bronchioles. Now, if we look at a respiratory bronchiolar unit, this consists of a single respiratory bronchiole, and then its further branches or divisions. Here is the alveolar duct, and here is the alveolar sac, and it is surrounded by these alveoli. You can see that in the wall of the respiratory bronchiole, the alveoli are present. This is why gaseous exchange is possible over here. And then when it leads into the alveolar duct, this is the part which has alveoli throughout its wall. And then the atrium is the alveolar sac, and these are all the alveoli. So this constitutes a single respiratory bronchiolar unit. And you can see that here the lung tissue in this histomicrograph, it has a spongy appearance because of these spaces or cavities, which are the air-filled alveoli. Okay, so remember the part of the respiratory tract in which gaseous exchange occurs, namely the respiratory bronchioles, alveolar ducts, alveolar sacs, and alveoli. This is collectively called the respiratory portion of the air passages. But remember, it is the alveoli that are the actual sites of gaseous exchange between the air and blood. The surface area available for gaseous exchange is increased by the presence of the alveoli. Now, the alveoli can be explained to be sac-like evaginations, each about 200 microns in diameter, arising from the respiratory bronchioles, the alveolar ducts, and sacs. And there are about 150 to 250 million alveoli in each adult lung. And their combined internal surface area is approximately 75 meters square, which is roughly the size of a tennis court. If we look at the wall of the alveoli, we will see the lamina propria is extremely thin, consisting of a network of elastic and reticular fibers. These closely surround the alveolus. And plus, there is a network of capillaries over here that is prominent in the sparse connective tissue surrounding the alveoli. Between the neighboring alveoli, there is the thin interalveolar septa, which consists of reticular and elastic fibers, a little quantity of extracellular matrix, and a few scattered fibroblasts. Also, the alveolar pores, these are the connections or communications between the adjacent alveoli, which are 10 to 15 microns in diameter. They penetrate the interalveolar septa. Now let's discuss the lung vasculature. The blood circulation in the lungs, you should know, is dual. Now, why is there a dual blood supply in the lungs? Well, obviously, first we have the pulmonary circulation, which is going to bring oxygen-depleted blood for gaseous exchange. Whereas the other blood supply coming to the lungs is the bronchial circulation. This is the one which is carrying the systemic nutrient and oxygen-rich blood to the lungs. So here is a diagram which is showing us the pulmonary acinus or lobule. Within the lung, you can see here is the bronchiole, which has then further branched into a terminal bronchiole. And from the terminal bronchiole arises the respiratory bronchiole, and then the alveolar duct and the alveolar sac and the alveoli. You can see over here that this is the pulmonary artery, and this is the branch of the pulmonary artery which then accompanies the bronchial tree. And as the bronchioles are going to branch further, the pulmonary artery also branches and accompanies this here bronchiolar pattern. At the level of the alveolar duct, the branches of this pulmonary artery form dense capillary networks which are present in between the alveoli, or we could say they're present in the interalveolar septa that contact the alveoli. The pulmonary venules and veins, if we look at them over here, the pulmonary venules and veins, they are not present alongside the bronchiole, but they are present in the connective tissue which is present between the pulmonary lobules. Over here in this diagram, you can also see these alveolopores of Kohn. These are the communications between the adjacent alveoli. Also, you can see that the alveoli are surrounded by these thin elastic fibers, and a very small quantity of connective tissue is present between these alveoli. So if we were to describe the bronchial circulation, remember the key points. First, that the bronchial arteries, they're representing the systemic circulation, which is providing the nutrient-rich and oxygen-rich blood to the lung tissue. And these bronchial arteries are, remember, the lateral branches of thoracic aorta. Also, like I showed you in the diagram, they run with the bronchial tree. They distribute blood to the lungs as far as the level of the respiratory bronchioles, where then they anastomose with the pulmonary vascular system. So if we go back to this diagram, we can see here is the pulmonary circulation showing us the branches of the pulmonary artery. And as they have broken up over here into a network of capillaries, remember that over here an anastomosis is going to take place also with the branches of the bronchial artery. So the main bronchial veins, they drain into azygous and hemiazygous veins. Coming specifically to the alveoli, when we talk about alveolar epithelium, it is composed of two types of cells, type 1 and type 2 alveolar cells, which are also simply called the type 1 and type 2 pneumocytes. Let's enumerate the important points regarding the type 1 pneumocytes. These are the cells which are extremely flattened cells, and they, remember, are constituting 40% of the entire alveolar lining cells. But since they are flattened, the area that they cover is about 95% of the alveolar surface. The organelles are present clustered around the nucleus, and the adjacent type 1 pneumocytes are attached or joined to each other by these tight junctions, also known as the occluding junctions, to prevent leakage of tissue fluid into the alveolar airspace. Remember, these cells are not capable of cell division. Now let's come to the type 2 pneumocytes. The type 2 pneumocytes, which are the other type of alveolar lining epithelial cells, are also called septal cells. Their shape is cuboidal, so they bulge into the airspace. Now, they make up about 60% of the entire alveolar lining cells. So their quantity, their number is more in comparison to the flattened type 1 pneumocytes. But since their shape is cuboidal and not flattened, so they cover only about 5% of the alveolar surface. Now, also present amongst the type 1 pneumocytes, they are present in groups. So they tend to occur in groups where two or more alveolar walls unite. So these points are known as septal junctions. And at the septal junctions, the type 2 pneumocytes, they tend to occur in clusters or groups. They have the ability to divide, and they replace their own population, as well as also, remember, they are the progenitor cells of the type 1 pneumocytes. Type 2 pneumocytes, they have the cytoplasm, which is filled with granules. And if we look at this in the electron microscope, we can see that there are small lamellar bodies. Lamellar bodies, they contain the parallel membranous lamellae. And these lamellar bodies are seen to actually contain a mixture of phospholipids, neutralipids, and proteins, which is eventually secreted by exocytosis, and this forms an alveolar lining surface active agent called surfactant. So here we can see on the left is a simple drawing, and on the right we can see the transmission electron micrograph showing us this here is the cytoplasm of the apical cytoplasm of the type 2 pneumocyte containing these membranous granules, and within these granules you can see there are these lamellar bodies. So over here, these lamellar bodies, they are going to secrete this material, which is known as surfactant, onto the surface of the lining epithelial cells. And this is a surface active agent. Let's look about this surfactant. What we want to remember about this substance is that it lowers surface tension at air epithelium interface, and this helps prevent the collapse of the alveoli during expiration. And it also allows the alveoli to be inflated with less inspiratory force, easing the work of breathing. Now, what is the surfactant chemically composed of? Well, you have the phospholipid dipalmitoyl phosphatidylcholine. So this is the chemical substance present within the surfactant, and it also has cholesterol and 4 surfactant proteins, 2 SPA and D for innate immunity, and 2 proteins B and C for maturation of this phospholipid dipalmitoyl phosphatidylcholine. Now let's talk about the clinical correlation alongside the histological anatomy. When we discuss surfactant, there is the clinical condition which is common in premature babies, that's the infant respiratory distress syndrome, which is abbreviated as IRDS. This occurs in the premature babies due to a deficiency of the pulmonary surfactant. And this can cause severe acute breathing difficulties as well as persistent chronic lung disease. And the treatment would be with the continuous positive airway pressure, or we can also administer glucocorticoids, which stimulate the production of surfactant, or artificial surfactant can also be administered. Now that we have discussed the surfactant and the main characteristics of type 1 and type 2 pneumocytes, let's come to the next part of this discussion, which is on the respiratory membrane, also known as the blood-air barrier. The air in the alveoli, remember, is separated from the blood in the capillaries by 3 components, and they are collectively known as respiratory membrane or blood-air barrier. These 3 components are, number 1, the type 1 pneumocyte, which is the highly flattened cell lining the alveolus. The second component are the fused basal laminae of this type 1 pneumocyte and of the capillary endothelial cell. So the third component is, of course, the thin endothelial cell of the capillary. Collectively, these 3 components are known as the respiratory membrane. So these are the barriers across which gaseous exchange is going to take place. The total thickness of these layers, or we could say the total thickness of the respiratory membrane, is about 0.1 to 1.5 micrometers. The thinnest part is the site of gaseous exchange, and connective tissue cells, fibers, and macrophages, remember, can also be found within the septa where tissue fluid can accumulate. The alveolar pores, as I showed you before in the diagram, the alveolar pores which are present in the interalveolar septi between the alveoli, they equalize pressure amongst the alveoli, and this is more important in case of any pathology where there is some blockage. The alveoli distant to the blockage sites may continue to be aerated because of the presence of these pores. So here let's look at the simple diagram which is showing us these alveoli. You have these alveoli, and between these alveoli you can see this is the interalveolar septum, and within the interalveolar septum here is a pore. These are the alveolar pores. One is over here and one is labeled over here. So they establish the communication of the air between the adjacent alveoli. And now where is the respiratory membrane? Well, you can see that between the alveoli, these are the blood capillaries. So the respiratory membrane is formed by the endothelial cell, which is lining the blood capillary, plus the flattened type 1 pneumocyte or type 1 alveolar epithelial cell, which is present in the wall of the alveolus. And then between these two are their fused basal laminae. So here, if you just follow the laser pointer over here, I'm pointing towards the respiratory membrane, and this is the site across which the gaseous exchange is going to take place. Also, we can see some other cells over here, like these over, you can see type 2 pneumocytes. They are cuboidal and they are projecting into the alveolus. And then, of course, some macrophages are also present in the interalveolar septi. Here is an inset where the respiratory membrane has been magnified. And over here, we can see this is the erythrocyte within the endothelial cell. And here's the wall of the endothelial cell. And over here is the alveolus. And in the wall of alveolus, this is the type 1 pneumocyte or alveolar epithelial cell. And here are their fused basal laminae. And this is the respiratory membrane collectively. And you can see that oxygen is now going to diffuse into the blood capillaries, and carbon dioxide is going to diffuse out of the blood capillaries into the alveoli during the process of aeration. If we look at a transmission electron micrograph, and this is a highly magnified view where we can see the respiratory membrane, then here you can see E is the endothelial cell lining wall, and here P1 is showing us the type 1 pneumocyte, and between them is here the fused basement membrane. So this here is the respiratory membrane or blood-air barrier as we can see it in a highly magnified view with the help of the electron microscope. Now let's talk about the clinical condition which is related to this discussion, known as COPD, that is chronic obstructive pulmonary disease. When we say COPD, it includes emphysema and chronic bronchitis. What is emphysema? In emphysema, there is a progressive destruction of the alveolar ducts, sacs, and alveoli, leading to permanent dilatation of the air spaces, but a marked reduction in the surface area for gaseous exchange. Also, there's a loss of elastic tissue support for the bronchioles, and that leads to their collapse and trapping of air. There are other cell types also in the alveolar wall. Remember, there are brush cells. They are few in number, but they may serve as receptors that monitor the quality of air in the lung. Also, as I showed you in the diagram, are the macrophages. They are found in both alveoli and interalveolar septum. They are basically derived from monocytes. They're also known as dust cells. This is because they they collect the inhaled particulate matter, that is the carbon particle or silica or pollen, and then they acquire a slightly darker color in comparison to the type 2 pneumocytes. So then these macrophages will be called dust cells. And dust cells, remember, obviously are more in number in those who are exposed to polluted air, that is the smokers or in urban dwellers. People living in the city, they are more exposed to such pollutants. Another medical terminology is the heart failure cells. This is the name which is given to those macrophages which are present in case of the congestive heart failure within the lungs. So what happens is that when there's congestive heart failure, the lungs become congested with blood, and the red blood cells, they pass into the alveoli, and then these cells, they are taken up or phagocytosed by alveolar macrophages. And now these alveolar macrophages, which have taken up the erythrocytes, they are called heart failure cells, and they are present in the lungs, so they are present in the sputum. And they can be identified by the positive histochemical reaction for iron pigment within the sputum. Also remember, the macrophages which are present within the lungs can phagocytose infectious organisms such as Mycobacterium tuberculosis, and then that can be recognized in the cells in appropriately stained specimens. So the sputum would help in identifying the disease. These bacilli are not digested by macrophages, keep that in mind, but other conditions or infections can therefore cause the release of the bacteria and recurrent tuberculosis. This is the graph, which is a very good one from Ross's Histology textbook and atlas. So this is the one which is showing us the summary of the histology of the respiratory tract. We can see the bronchial tree in which you have trachea and then the bronchi dividing into these bronchioles, and eventually this here system where we can see the respiratory bronchiolar unit. And as we go downwards in this bronchial tree, we can see the changes which take place regarding epithelium, the cells, the glands, cartilage, the smooth muscle, and elastic fibers. So what we should keep in mind is that, as I'm going to summarize, I mentioned this in the part 1 of my histology of respiratory tract lecture, that we divide the respiratory system into a conducting part and the respiratory part. So the conducting part is the part which is going to transport or carry the air to the respiratory passages, but itself doesn't take part in active gaseous exchange. So the conducting part consists of the trachea, the main bronchi, and then the secondary or lobar bronchi. Then you have the tertiary or segmental bronchi, and eventually we have the bronchiole when the diameter is 1 millimeter or less. And then that further divides into terminal bronchiole. Now, from the terminal bronchiole onwards, when we get the respiratory bronchiole onwards is the respiratory portion of the respiratory tract, meaning this is the part where gaseous exchange is going to take place. So this consists of the respiratory bronchioles and then the alveolar duct sacs and these grape-like bunches of the alveoli. Now, what are the changes in epithelium which take place? Well, in trachea, if you recall from the previous discussion, we know the epithelium is pseudostratified ciliated columnar epithelium, and the same epithelium is present in the larger principal bronchi. But the height of the epithelium, it decreases, and eventually it transforms from the columnar epithelium to eventually the cuboidal epithelium. And we can see in the alveoli, we have the flattened epithelial cells, mainly which are the type 1 pneumocytes. But there are also the type 2 pneumocytes. We discussed them before. Let's look at the cell population, which is known as the goblet cells. Goblet cells are the mucus-secreting cells. They are present mainly in the trachea, the principal bronchi, and the larger bronchi. But they decrease in quantity as we move further downwards towards the bronchial tree, and they are not present within the alveoli. And then the ciliated cells also are present in greater quantity within the conducting part of the respiratory tract, but from the bronchiole onwards, you can see their quantity decreases. What I want you to notice over here is that this is a tapering transition. So no transition is abrupt. Whatever changes take place, they take place gradually. And in the case of glands, we can see that respiratory bronchiole onwards, we can see there are no glands now. Also, there is no cartilage. So the bronchioles, you can see over here, they do not have glands and they do not have cartilage. Remember that important transition which is taking place within the bronchioles, that the glands and the cartilage will have disappeared. Although smooth muscle is present in the bronchioles, and it is present in much lesser quantities within the alveolar sacs and alveoli. Elastic fibers, they are present throughout the major portion of the respiratory tract, although their quantity has decreased slightly if we look at that in the alveoli. So this is a very good pictorial representation of the changes which take place at the histological level within the respiratory tract, and it can help you revise these changes very easily if you just take a few minutes for this one. And this is a table also. This table is from Jen Cora's Histology textbook and atlas. And this also summarizes the same changes that I mentioned. And it also correlates these changes with the action of the respective parts. So you can look at that later. You can look at that in your textbook, or you can simply see this video again, and you can go through these in detail. It's the same thing that I just discussed with you. So now that we have covered the histology of the respiratory tract, I'm sure if you look at this micrograph over here, considering the part 1 in which we discussed the histomicrographs, you should be able to identify which structure you can see over here. This is the bronchiole. You can see the pseudostratified ciliated epithelium that is slowly, transitions into the columnar epithelium, and it is surrounded by the smooth muscle. And you can also see connective tissue over here. And in this micrograph, you can also see the respiratory alveoli. But this has been recognized as bronchiole. Like I told you, there is absence of cartilage and absence of glands. So that is why we can recognize this section to be a section of the bronchiole. Now here comes another micrograph, and we can see that this here is the lung tissue. But what about these passages which have been labeled here? Well, if you look at them, then you can see number 1 is a blood vessel. Number 2 is the respiratory bronchiole, which then leads into, you can see these here alveolar ducts. And number 4, these are the alveolar sacs, and they're surrounded by these alveoli. These are the micrographs, the similar one, the transmission electron micrograph. It is quite similar to the one I'd shown you before of the respiratory membrane. So over here, if we can see the respiratory membrane, number 1 is the lumen of the alveolus. And you can see that number 2 is the type 1 alveolar cell lining this alveolus, whereas number 3 is the endothelial cell. And between them is their fused basal laminae. And this now collectively forms the respiratory membrane or the blood-air barrier. And here number 4 is simply the lumen of the capillary blood. Okay, and number 7 is the fibroblast present in the connective tissue of the interalveolar septum. So at the end, I would like you to be able to answer this question. And the question is quite simple. You have the pulmonary, which is the functional, and the bronchial, which is the nutritive arterial systems. These are 2 blood circulations entering the lungs separately at the hilus. But like I showed you in the diagram, that these 2 separate blood circulations tend to anastomose. They are going to anastomose or mix with each other into a single system within the lungs. But at which level will this mixing take place? This takes place at the level of the respiratory bronchioles. Then the other question is a clinical scenario in which a girl she presents to the AR with paroxysms, or you could say attacks of shortness of breath, cough, and wheezing. Her parents show that she has been having these attacks during the past winter. So they're related to the winter season, and they have worsened, but they become more frequent during spring. Now, which of the following cell types and their location is correctly matched to a function it may perform in this patient's disorder? In this case, the correct answer is D, the mast cells in BALT. BALT stands for the bronchus-associated lymphoid tissue. And in this case, the mast cells are the cells which are going to be reacting. In this case, this is a seasonal allergic reaction. So the mast cells are involved, and this allergic reaction causes bronchoconstriction. That is the bronchospasms of the constriction of the smooth muscle in the walls of the bronchioles, and also edema. So this is responsible for the symptoms of dyspnea, that is shortness of breath, and cough and wheeze in this girl who is having these seasonal attacks of bronchospasm, which are these allergic attacks. This was the answer to this question. So these 2 video sessions which were discussed, in which I have discussed histology of respiratory system, they were prepared mainly from these books, which I am showing you in this last slide. And I hope that this was elaborate enough, and at the same time, it summarized the key concepts of the histology of the respiratory system. So if you like today's lecture, I would like you to subscribe to my YouTube channel, which is AnatomyMentor. And you can do that by simply pressing on my picture, which is going to appear at the end of this video. And so best of luck studying, and I will be coming back with another topic next time. Thank you and take care.